Hi, happy lunch, everybody. I'm Dr. Jan Harris, and I teach in the English department. And it is my distinct privilege to introduce to you our keynote speaker for the lunch today, Dr. Jean Anderson. And I've just had great fun getting to know her. Dr. Anderson is a well-renowned medical doctor who graduated from Vanderbilt. But before Vanderbilt, I learned today, from the 7th grade on, she went to the campus school at David Lipscomb and then received her BA from Lipscomb University, which was, at that time, I think, David Lipscomb College. Help me out. Okay. I'm the lone faculty member that did not go here. Okay, so help me. I know none of the coding. All right, so I really enjoyed getting to know Dr. Anderson and the commitment to her research, and we spent some time talking about Baltimore, where she lives. And that she enjoys a lot of outdoor things like I do. For those of you that know me, she likes kayaking, distance bike riding, which I told her is phenomenal. I like distance running, and I'm still struggling with bikes and other sports equipment. And so it's really nice to meet her. But the most significant thing that I want you to take away from this is that she has a dog whose name is Maggie that she loves. And it's a German Shepherd, and I realized that she and I were meant to be soulmates because I have a dog named Malloy, who is a German short-haired pointer, so Maggie, Malloy, German-ish dogs. So it was fate. It was fate for us to meet. But in all seriousness, Dr. Anderson is a real role model for us, an example of the kind of scholarship that Lipscomb has the history of producing. She works with a community that has great need, the HIV community, and she has been bravely working with them since the early years of HIV. And if you think about what we didn't know 20 years ago about that disease and the progress that has been made, and that Dr. Anderson has been on the front lines of this research and development. Another interesting thing about her is she's going on a 140-mile distance bike ride for a charity for HIV research, a movable feast who works with HIV patients and gets nutritious meals to them and is supportive research. So not only in her professional life does she support her research, but also in her private life and her pastimes. So it's my distinct privilege to welcome Dr. Jean Anderson to speak to you today. Please give her a round of applause.
Well, good morning. And it's a real pleasure to be here. I want to thank Dean Burgess for giving me the invitation to come back home. What I wanted to tell you in just a few minutes is a little bit of the story of HIV and AIDS, and some personal comments along the way, because it's really been a true privilege to be a minor part of this story, really, but it's a case of serendipity, being in the right place at the right time. And I'm entitling it The Lazarus Disease, and I think that'll become a little bit more clear as to why it's often called that. This is an iconic photograph. I don't know if any of you have ever seen this before, and this was actually a controversial advertising photograph for Benetton back in the early 80s. And this was where AIDS was when I was beginning to get into this. This is a photograph of a young man who is in San Francisco who has just died from AIDS, and his family. And so I wanted to tell you a little bit about the history. And I don't know of any example, really, in medical history of a disease that has had the sort of trajectory that HIV has. From coming out of nowhere, not being recognized as a disease. I'm going to date myself, but when I was in medical school, I never heard about HIV because we didn't know about HIV. When I was a resident in obstetrics and gynecology at Vandy, never saw a patient with HIV. We were just beginning to hear about it. And then it wasn't until I moved to Johns Hopkins that I saw my first patients with HIV. So let me tell you a little bit about the history. It was first recognized as a syndrome in 1981, when there was a cluster of really weird unusual types of pneumonia called pneumocystis pneumonia that were diagnosed in some different areas. And I remember seeing the first report in 1981 in one of the major medical journals. And first of all, this was felt to be a disease. In fact, it was first of all called GRID, a gay-related immune deficiency, because it was felt to only affect gay men. And in fact, it was thought not to affect women. And my focus as an obstetrician gynecologist has been on women with HIV. But when I came into this field, there were very few women who had been recognized. And so in 1981, this was a quote from the New York Times: "The best evidence against contagion," at that time we didn't even know it was an infectious disease, "is that no cases have been reported to date outside the homosexual community or in women." That was in 1981. So the next year, there were 24 cases of pneumocystis pneumonia, Kaposi sarcoma, and other opportunistic infections associated with AIDS that were reported in women in the CDC. So very quickly, we started seeing a broader picture of this disease. And in December of that year, in 1982, it's the first case of mother-to-child transmission. So we're beginning to get a broader picture. So then very quickly, I mean, we went from knowing, is this, what kind of disease is it, to evidence that it's an infectious disease. We still didn't know what caused it. So in 1983, the virus that causes AIDS was isolated. That was controversial for a while, and there were some real HIV deniers. In 1985 was the development of the first serologic test so that we could diagnose it, because we had no means of diagnosing HIV. It wasn't until 1986 that the first antiretroviral agent, AZT, was developed. And this was felt to be a godsend. This is where I sort of entered the picture. I moved to Hopkins in 1986. And at that point, we still didn't even have AZT. And I can tell you a little bit about those early days and sort of how I got into it. As many of you who perhaps are newer faculty or even newer students might relate to, when you first go to a new place, you're kind of casting around as to what you're going to sort of focus on. And I knew one person when I went to Hopkins who had trained at Vanderbilt at the same time I did, and she was an infectious disease fellow. And she called me one day and she said, we're beginning to see just a few women with HIV, and we need a gynecologist, and wondered if you'd be that gynecologist. And I said I would. And so I sort of just fell into it. And I can tell you that today my clinic and my program accounts for over a third of all the patients with HIV who are followed at Hopkins. So in those very early days, it was a pretty daunting time. Again, remember, we didn't know very much about it, and we had less to offer. We could treat some of the opportunistic infections, so we could help people live a little bit longer, but we would have weekly meetings, just like people do today in clinical settings, and discuss patients. But at that time, those meetings were basically death lists. We reviewed who had died and who was about to die. And it was it was a time of great camaraderie, though. I'm proud to say that our group at Hopkins that was caring for these patients, we had the lowest turnover of any clinic in the hospital. People really were dedicated. And my closest friends at Hopkins come from that era. But at that time, it was difficult. It was more difficult in many ways than dealing with other life-threatening illnesses, partly because there was this fear about it. Once you realized it was infectious and you didn't know how it was transmitted. I had residents who refused to operate with me because I took care of AIDS patients. And there was a lot of stigma attached because this really attacked the most deprived patients in our society. So the Department of Medicine at Hopkins actually hired a psychologist for the providers, and we would meet on a regular basis. So that's where AZT came in. And AZT, we thought it was the answer. And we saw people start getting better. People who were on the door of death start gaining weight again, getting better, and that lasted for about 2 years, and then they started going downhill and died. And we realized later that what had happened is that the virus had developed resistance to AZT. So around this time, there were also a lot of things that were happening societally that really impacted on HIV. The first is ACT UP. Does anybody remember ACT UP? Yes. ACT UP was an activist group. It was largely initially gay men, many of whom had HIV and AIDS and were dying, and felt that the medical community was doing little to nothing to address this. And they started agitating, and I remember going to international meetings where they would have demonstrations and they would tear down things, and they would, it was, but they also acted very constructively within the government, within the NIH. And they really pushed the research agenda for HIV. And they are really responsible for a lot of the early research that occurred in HIV to develop treatments and to develop antiretroviral agents. And then there was a young boy named Ryan White. Anybody heard that name? Ryan White was a 13-year-old with hemophilia and lived in Indiana, I believe, and was diagnosed with AIDS at the age of 13. And there was such a reaction by his community against him. He was banned from school. And his parents and he really took up the banner and fought and took it to the government in Washington. And in 1990, the Congress passed the Ryan White Act. He died earlier that year. And the Ryan White program is the program that has funded most of the care that I've provided. It's funded the clinical care, more clinical care for people with HIV in this country than any other single entity, as well as funding money for antiretroviral drugs for people who can't afford it. In 1991, Magic Johnson, I'm sure a lot of you know who Magic Johnson is. So Magic Johnson was an Olympic star, a basketball star, and in 1991, he came out and said, "I have AIDS." And he was one of the first celebrities to openly admit that he had HIV. And I can tell you the difference that made in terms of the stigma. I mean, all the things the healthcare providers had been doing for a decade to try to reduce the stigma and the fear, even within our own ranks, he did with that one statement and made a huge difference. 1994, I was one of the investigators involved in the 076 study. There were many throughout the country. This was a landmark research study. It was the first study to show that an antiretroviral drug could prevent mother-to-child transmission of HIV and cut it by 2/3. And that was with AZT alone. So the first decade for the patients, most of them died. Virtually all of my patients from that era have gone. And they died terrible deaths, wasting, dementia, diarrhea. They dealt with stigma and discrimination in society and within the healthcare setting. Many of these patients were abandoned by their families. There was a lot of secrecy. They were afraid to tell people they had HIV, and many times people, even when they died of HIV, Their obituaries never mentioned the word. They said cancer, or they said a chronic illness or something else. And there was no treatment. But meanwhile, a lot, for all of the reasons I've mentioned, was going on in the healthcare and scientific setting. We learned about the cause of HIV. There was better understanding about the epidemiology, the natural history. We developed a diagnostic test and the first drugs. This was, again, a picture from the early days. This was the AIDS quilt. And this was started by a group out of San Francisco, and it quickly spread around the country. And when someone would die of AIDS, people got together and made a quilt piece, a quilt square. And this was in the early 80s, what it looked like. It grew to be so big it could not be displayed in one place. But this was still when it could be displayed. And so you can see that's on the National Mall in DC. So then things began to change pretty dramatically, and really miraculously. And probably the biggest thing that happened was in 1996, and that was the recognition that a combination of drugs was needed. Not just one antiretroviral drug, but a combination, usually 3 or 4 drugs, sometimes we use 5 now, that attack the virus in different points in its life cycle and that helps prevent resistance developing, because this is a very mutation-prone virus. And if you just have one drug and you hit it there, it's very smart, just goes around it. And so the idea was being able to hit it from different angles and really suppress the amount of virus in the blood. And so shortly afterwards, for all the studies, all of the clinical trials were done, started using viral load. That was another test that was developed in the late 80s, but where you could actually measure the amount of virus in each milliliter of blood. And when people would come in with more advanced HIV, it was often in the millions per milliliter of blood. We have a test now that is able to detect, undetectable is less than 20 copies of a virus per milliliter. So we can detect it down to that low with a clinically available test. And so viral load became the endpoint for clinical trials, because we realized that if you could control the viral replication, then you could control the virus and could control the disease. In 2003, another important policy, and I'll say a little bit more about this in a moment, was the development and the authorization by Congress of PEPFAR, which stands for the President's Emergency Plan for AIDS Relief. And this was put forward by President Bush. I was privileged to be at the signing ceremony when he signed this. And this was the first real program to give international support. Because as I'm going to show you in a minute, the biggest problem has been not in the US, but it's in very low resource settings. In 2008, there was actually, I don't know if anybody noticed it, but there was actually a cure of HIV. It's an interesting story. It was called the Berlin patient. He was anonymous for many years, but he was a man in Germany who had AIDS and was being treated but wasn't doing really well. And then he developed leukemia, and he ended up, he didn't do well with the chemo, and he was given an experimental treatment using stem cell transplants. Well, it just so happens that the donor stem cells was from somebody who has an interesting genetic mutation that makes them resistant to HIV. And he is still alive and still free. There's no detectable virus in his system. So it was the first and what we call functional cure of HIV, and that's still sort of the holy grail for HIV. From 2011 to 2013, the real changes have been a renewed focus on prevention. I'm going to show you some statistics, and we'll say it again later, but we can't treat ourselves out of this disease. We've got to prevent it. And unfortunately, the new number of cases has not changed that much in this country. And there are a couple of studies that have been landmark studies. One looks at what's called TASP, treatment as prevention, showing that treating the infected person reduces their viral load enough so they are less likely to transmit it to someone else. And the other is called PrEP, pre-exposure prophylaxis, where you give an antiretroviral combination to an uninfected person who is at high risk for getting HIV. And these advances have led to the year 2013, where the motto for the International AIDS Conference was an AIDS-free generation. And this has become sort of a mantra that this is a possibility. It's not a reality yet. So where are we today? From 2006 to 2009, the estimated number of U.S. individuals living with HIV has increased by 8%. That's because we've gotten better at treating it. People aren't dying as often from HIV, but they're living with HIV. But it also is because about 50,000 new HIV infections continue to occur each year in this country. There are more than 1.2 million individuals 13 years and older in the U.S. who are living with HIV now. Almost 1 in 7 in the U.S. who have HIV don't know they have HIV. They may not even know they're at risk for HIV. We now can achieve transmission rates from mother to child of under 1%. And in my program, we haven't had an infected baby in over 5 years. And life expectancy in somebody who is treated effectively and treated early is similar to the general population. And this shows the dramatic difference in a decline in mortality rate from HIV infection. And this shows the decrease in mother-to-child transmission rates. Started out at baseline at about 25 to 30%. AZT alone cut it in by about 2/3. And then what happened is that really outstripping the research in mother-to-child transmission, which lagged behind because of concern about doing research in pregnant women. But research was proceeding, and there were new drugs being developed, and so we entered what's called the combination antiretroviral era. Well, of course, some of those women became pregnant, and what we started noticing is that the rate continued to decline, and the most recent data from the UK showed that it was under 1%. This is just a picture of where new HIV infections are occurring in the US, and you can see that the Southeast is a leading area in terms of new HIV cases among women. Where I live in Maryland is also a very high prevalence, high incidence area. This is one thing that a lot of people, I think, still may not understand a lot of people still have this picture of HIV from the early days, and they have a lot of stigma attached to HIV and those who get HIV. For women, the largest risk factor is heterosexual activity. You can see that if you look by race and ethnicity, 90% of new HIV cases among African American women are related to heterosexual risk. And Hispanic and Latino women, it's about 86%. It's about 3/4 in Caucasian women. And this is actually a disturbing slide. This was a study that was performed in, I think, 5 urban areas, one of which was Baltimore, one of which was Washington, D.C., these communities had high HIV prevalence. And what they found is that, first of all, 1.5% of women, this was geared towards women, were found to have HIV at the baseline. These were women who didn't know that they had HIV. So they went into these communities. They recruited over 2,000 women. They did testing. And they found 1.5% of them already had HIV. But then when they followed them longitudinally, they found that their incidence rate, their rate of new infections, actually was 5 times higher than what the CDC estimated for the general population, and higher than many African countries. And again, these women were largely minority women. They were largely poor. And this is also a disturbing slide. It showed that in black women with HIV are more than twice as likely to die of AIDS than white women with HIV. And I think there are a lot of reasons for that. But it shows that we still have a huge problem in this country with stigma, with access to care, with dealing with other comorbidities such as depression, violence, things like that. And then this is what's called the HIV Continuum, and it shows some of the challenges we currently face with HIV. I mentioned the fact that you have to know you have HIV before you can access care, and that there's still about 18% of people who don't know that they have HIV. But even when you look at rates of diagnosis of HIV, and then there's a steep drop-off in those who actually get into care. And there are a lot of reasons for that. Some of that's stigma-related. Some of it's the fact that HIV has a long asymptomatic phase, about 10 to 12 years, when people feel fine. And they may say, I'm fine, I don't need to get care. Or they may say, I don't want anybody to know, or I can't afford care. Or for women, a big issue is taking care of their families. And many of my early patients prioritize their family's needs over their own. And often, keep in mind, this was a family disease. The woman may have, and her husband may both be infected. They may have a child who's infected. So it's a huge step off between diagnosis and getting care, and then further step off in terms of receiving appropriate treatment and taking that treatment with good adherence. I don't know about you all. I was telling some folks yesterday that I have a hard time finishing a 10-day course of antibiotics. And you're talking here about taking a medication the rest of your life. And there are many illnesses where you have to take lifelong medication, but one of the differences with HIV is if you don't take it correctly, if you start missing doses, you do develop resistance, and that resistance is lifelong. So you are resistant to those drugs. You may be resistant to other drugs in that class. And I've had patients who've died because they ran out of options. They had developed resistance to every single drug. And we follow their viral load, and that's how we get a sense of, are these drugs working? Are they taking them or not? This was another advertisement, a more recent advertisement, but still not that recent, because you see Nelson Mandela, you see Elizabeth Taylor, and it says, we all have AIDS if one of us does. And it was one of the efforts to try to rethink the way society was dealing with this disease. I work a lot these days in Africa, in various countries, and AIDS is still a huge raging problem. There are many, many children who've been orphaned by AIDS. In Ethiopia, there's an AIDS. They are called AIDS orphanages. The this one in Ethiopia cares for children whose both parents have died of AIDS. This in 2012 was a global summary. About 35 million people living with HIV. About half of them are women. 3.3 million are children under the age of 15. About 2.3 million newly infected individuals with HIV, and about 1.6 million deaths. And this is from 2011, but I thought it was just that hasn't been updated. But if you look at where these infections, where people with these infections live, you can see that the largest number in sub-Saharan Africa, 23.5 million individuals. And if you look at other areas where there's a higher prevalence, you look at North America, Latin America, Eastern Europe, Southeast Asia South and Southeast Asia, including India, are all large numbers, but they are totally dwarfed by Africa. This is a mathematical projection of the effect that antiretrovirals in these areas, in low and middle income countries, can have on death rates. So the red is without antiretroviral therapy, and the blue is with antiretroviral therapy. And I remember prior to PEPFAR, the international conferences on AIDS, there was pretty much not much talk about Africa or Asia or any other low income place in the world with HIV, because people didn't believe it was going to be possible to treat it there because the drugs were so expensive. And then PEPFAR and also the Global Fund for AIDS, TB, and Malaria, which is a global community where countries around the world donate funds, came into being. So this is the latest statistics I could find, antiretroviral therapy coverage in low and middle income countries for adults and children as of December 2011. And the main thing is the last column, which shows the therapy coverage. This is of those who need therapy, how many are getting it. So still not doing great. I mean, doing fantastic compared to a decade ago, but still only 56% of individuals with HIV in Africa who need therapy have access to therapy. 68% Latin America and the Caribbean, 46% in Asia, in East, South, and Southeast Asia, and then you can see from there. So let me say a little bit about prevention. I think at the beginning when we thought about prevention, we thought about, there was ABC, abstinence, be faithful, and condoms. That was the mantra. We now have a better understanding, and there are all of the options on this slide have at least one study demonstrating effectiveness, one clinical trial. So certainly male and female condoms. Cash transfers, that's an interesting concept. It was trying to promote adherence, where you actually pay somebody to take their medicine. A recent study, though, out of New York showed it didn't work. Their vaccine development has been one of the disappointments in the AIDS research field. But there actually is one vaccine that has been shown to be partially effective, about 30% effectiveness, not great. I'm going to say a little bit more about PrEP, PEP. Microbicides have also been a little bit of a disappointment. These are gels or foams that can be used vaginally, rectally, by men and women. And the problem is that most of those have not shown to be effective. Clean injecting equipment for those who are injection drug users and are unable to stop use. Just learning, just counseling and testing has been shown to be effective in improving care and preventing transmission. Male circumcision, huge push in Africa now. That's shown to reduce the risk of transmission from infected females to males by about 2/3. So many countries in Africa, this was first noticed, interestingly, it was an observation that countries in Africa where circumcision was the norm had much lower rates of HIV. And so then it sort of developed, and there were 3 major clinical trials in Africa that demonstrated conclusively that this was an effective intervention. But arguably, the most effective interventions for prevention are the same interventions for treatment, which is antiretroviral drugs. I think most of you may have heard of post-exposure prophylaxis. If I got a needle stick in surgery from somebody who was HIV infected, I'd take a course of antiretrovirals for a month, and that would reduce my risk of getting infected by about 80%. I mentioned prevention of mother-to-child transmission. That's giving the woman who is infected an effective combination of drugs. We're treating her at the same time, but it reduces risk to her baby to under 1%. Treatment as prevention. There was a study that was published about 3 years ago where discordant couples, these were usually married couples who one was infected, one was not, and they gave the infected partner effective treatment earlier than they normally would for their infection. And then they had a control group where they delayed treatment until they normally would have started treatment. And what they found is when they compared the 2 groups, the early treatment group had a 96% reduction in transmission to their uninfected partner. And when they looked, some people say, well, it's probably closer to 100% because there were 4 transmissions that occurred. One, they think, was somebody who was already infected, but it was too early for the test to detect it. And the others, when they did genetic linkages of the virus, they found that they had not come from the infected partner. They'd come from somebody else. So. And then pre-exposure prophylaxis is the concept of giving an uninfected person who's at high risk a combination of antiretroviral drugs. So this might be a discordant couple. And there are a number of studies now that have shown that this can effectively reduce transmission. So where are we going? I mentioned this before. We can't treat ourselves out of HIV, so prevention is critical. We are at a point now where we are treating people with HIV earlier and earlier in the course of their disease. And that's for a variety of reasons. There's a whole body of research showing that HIV has a detrimental effect on the immune system, on multiple body systems, way before they start having symptoms. And so there's a higher risk of cardiovascular disease, of diabetes, of neurocognitive decline, of all sorts of problems. So we're really going towards test and treat. You know, somebody's tested, you're positive, start them on treatment. And in fact, the U.S. Public Health Service guidelines now recommend treatment at any CD4 count. CD4 is the measure of the strength of the immune system. And it used to be, started off, treat if it was below 200, then it went up to 350, then to 500, and now it's treat anybody. And one of the reasons, of course, is that that also is a public health prevention tool. There is the ongoing challenge that I referred to of adherence and retention in care. Somebody feels better, they stop taking their medicines, take it irregularly. They may stop coming into care because they have a lot of other issues that they're dealing with. And there is a whole cure agenda now. If you go back to that cure I mentioned in 2008, the FDA has just given approval to do further testing on genetic modification of stem cells to develop this same mutation, using genetic editing to develop this same mutation that would allow people to be immune to HIV. I wanted to finish with just some lessons my patients have taught me, because I think in medicine, you learn more from your patients than you do from books. Keep in mind, this is not a disease I learned about in school from any book. I never saw a case until I was on the faculty as a practicing physician. Two of the things that patients have said to me early in the course of the disease, these patients have died. The first one was quite striking to me. I was giving a talk, and most of the providers were, most of the audience were doctors, and, I was very, with all these statistics, and afterwards, I saw this woman off in the corner, and she came up to me, and I realized she was one of my patients. And she said, "Dr. Anderson, that was a really good talk, but one thing you don't understand, HIV is not my worst problem." And keep in mind, this was before AZT. This was before treatment. She was going to die, and she knew it. But she had all these other things in her life that she was having to deal with. And that was not her priority. And then it sounds like the opposite message in some ways, but another patient who had been a drug user, and when she found out she had HIV, she stopped using drugs. And she told me, and she came to work for me as one of my counselors. She said, "HIV is the best thing that ever happened to me." Stigma and discrimination are real, and they are barriers to health, physical, emotional, and spiritual. And that's true for patients, and that's true for providers, and that's true for society. Never stop learning. As I said, if I'd stopped learning, I wouldn't know anything about HIV, because I never learned about it. And never stop hoping, because if anything, this trajectory shows you it's how dramatically things can change in a pretty short lifetime. And I wanted to show you a photograph. This is also one of my patients and one of my counselors. She's worked for me in my program for the last 20 years. That's her daughter, Rakina. I delivered Rakina. Rakina was the first baby with HIV that I delivered. Rose, her mom, we didn't know she had HIV, so this was really early. And she found out afterwards that her husband used drugs, and she was infected, and Rakina was infected. She found out because Rakina started getting sick, and they were both tested. This is a little older picture. Rakina just finished her master's in nursing and is a nurse in Baltimore, and are very good, and I'm considered her godmother, and we're very good friends. And they said when I'm on sabbatical and I'm traveling a little bit, so they gave me a picture of them to take with me to visit all the places I'm going. And that's it. I want to thank you for your attention. I want to thank you, Dr. Burgess, for inviting me, and I'll stop there. I'm happy if there are questions. If there's not much time, I don't think, but I'll hang around if there's some questions. Thank you.